Okay, I think we have 10 people, 11 people. I think we can get started. Thank you everyone for joining us. I know it's a sunny day, so thanks for joining us. And we have a good group. And I also want to say that this is our first meeting for this new academic year. I want to take this opportunity to let everyone know a few people finished thrombosis training, within BC, and here they are. Ben, I know Ben's working at VGH now. We also have John Doring. John's not with us today, but he is currently working in Fraser. And we also have the other Ben, who is actually setting up a thrombosis clinic at the Royal Jubilee in Victoria. I've heard some good news. They've worked with the emergency department there and got a pathway going, not very dissimilar to us here or VGH. So congrats to Ben. And then we also lastly have Alejandro, who will be joining us at St. Paul's in 1 month. So congratulations to everyone. These were all the excellent talks by our fellows last year. The recordings are now available. So I will ask Shelley to send out the links later on in an email. You're welcome to review them. And Aggie and I were talking about making a website and put it up there. So we'll have more information for you probably sometime in the fall, but we'll make it accessible, perhaps a portal that you can sign in. I also want to remind everyone that these meetings are approved by Royal College for MOC credits. And before I hand it off to Elena, a few exciting things coming up. I actually been working with AstraZeneca regarding Dexanet Alpha coming up pretty soon, and we were in touch with Dr. Siegel from Ottawa. She will be here in BC, I think, for a presentation with the Blood Club, and we have kindly asked her to do another presentation for us for the BC Thrombosis Network. Tentatively will be September 16th, but I'll send out more detail later on. And then Aggie will also be doing a talk on the new algorithm for cancer-associated thrombosis in September. So exciting things coming up. Otherwise, I will hand over to Elena, who will be talking to us about catheter-associated thrombosis in cancer patients.
Thanks, Dr. Wan. I'm just going to share my screen. Can you hear me okay?
Yes, we can.
Okay, perfect. And can you let me know if you can see the screen?
Yes.
Okay, perfect. So my name is Alina. I'm an R5 in general internal medicine, and I'm working this year at St. Paul's as well as Ottawa, learning a little bit more about thrombosis. So thank you for having me today. We're going to be talking about catheter-related thrombosis in the context of malignancy. As an introduction, there has been increased use of long-term dwelling catheters for patients with cancer over the last few years. Catheter-related thrombosis is the most common non-infectious complication associated with catheter use, making it a significant complication to consider when thinking about placement of these catheters. In regards to pathophysiology, we always go back to Virchow's triad and how it can contribute to the formation of these clots. First, from the vessel wall injury perspective, of course, we have endothelial injury from insertion of the initial catheter itself. There's hypothesized to be continuous friction of the catheters against the vessel walls, which can result in ongoing endothelial injury. And finally, depending on some of the medications or chemotherapies that are infused, there are known to be toxic effects, which can also cause endothelial damage. Of course, in the context of malignancy, we do know that hypercoagulability is an ongoing issue that we've always seen. And of course, with the catheters in place, there is altered blood flow through the affected vasculature, creating the perfect triad for thrombosis. In regards to how these thrombi are defined and formed, so they can form around the sheath itself, which is not really what we're going to be talking about today. Fibrin sheaths deposit on the external surface of the catheters, often within 24 hours of insertion. And this is just a layer of endothelialization that occurs in the context of anything that's inserted from outside the body to the inside of the body. There's also intraluminal clot, and this can form sort of a ball valve, where essentially flow can go into the vessels, but won't be able to come out of the vessels. And this often results from reflux of blood back into the catheter. And in the context of today's talk, we're going to be talking specifically about catheter-related thrombosis, which is basically a deep vein thrombus that partially or completely occludes the vein in which the catheter resides. So it's on the ipsilateral side that is affected. In terms of different types of catheters, I used to always get these very confused back when I was early in residency. And so a PICC line is shown here, and it is inserted into a superficial vein of the upper arm. Non-tunneled catheters are very infrequently used for long-term dwelling. They're usually sort of used in the acute setting in the intensive care unit, or just for short-term purposes. They're also called BAS cats. Tunneled catheters have a number of different names. Hickman catheters, Groschans are often used, perm cath. They are cuffed catheters, shown here. And then finally, we have portacaths or implanted ports, also called implanted venous access devices, IVADs, which are shown in this image here. In terms of what to look out for catheter-related thrombosis, it is very common to have asymptomatic catheter-related thrombosis because of that triad of different factors resulting in the formation of thrombus. However, there have not been sufficient studies to show that routine screening for CRT is recommended, as the benefits of treatment for this have not yet been made very clear. And so we say, really, before you're going to order an ultrasound, do consider if this patient truly is symptomatic and if a clot would explain the symptoms presented. These symptoms could include catheter dysfunction, swelling, pain, erythema, calor cyanosis, classic DVT type symptoms. Some patients will present with just an ache in the shoulder or jaw. Often on physical exam, dilated superficial vessels on the ipsilateral chest wall and neck can be visualized. And then symptoms of superior vena cava syndrome are also a common complication of CRT. In terms of epidemiology and risk factors, which we're going to look at next. So there's a wide range of incidents quoted in the papers. Upper extremity DVT represents at present 4 to 10% of all VTE. It was previously thought to be much less, but seems to have been increasing in frequency in the last few years. CRT represents the majority of upper extremity thromboses, often quoted to be sort of 70 to 80% of the cases that are seen. And in cancer patients, CRT is estimated to occur in 5 to 10 of the patients. 5 to 10% of the patients, sorry. The majority of CRT develop within 100 days, and we'll talk about some studies that were able to see that pattern as well. In terms of rates of catheter-related thrombosis, they have decreased with time, and this is thought to be secondary to improved methodology, so with the use of ultrasound guidance, as well as advancements in catheter materials that are less thrombogenic. So the first paper I'm going to talk about is just a paper that was published in The Lancet in 2013 by Chopra et al. And it was a meta-analysis looking at the risk of VTE in those with PICC. So this is only looking at one specific subgroup of catheters. And you can see here there were a large number of studies. Some of the studies that showed higher incidences, I would note, do seem to come from earlier, which is consistent with what we believe to be the trends of less CRT with time and more experience. And overall, they found that 6.67% of patients who had a PICC inserted ended up having a VTE event. So that's an approximation based on this study. And overall, I think it was about 3,000 patients who were included in the study. In this portion of the study for the cancer portion. However, we have a number of recent studies that are looking at very similar things, so epidemiology of catheter-associated thrombosis that are of very similar size. So This is a paper that was, sorry, I'm just going to move this. A paper that was published by Jacousis et al. In Blood in 2018. And it was a prospective multi-center study that looked at consecutive adult patients with solid tumor and implanted ports. So not the same as the last group. So this is implanted ports, not PICs, for 12 months. Their objective was to figure out risk factors for CRT and risk factors for VTE. The patients were primarily primarily mobile, so ECOG 0 to 1. 15% had previous VTE, 75% had right side implantation, 51% cephalic vein insertion, and at the time of enrollment, about 8% were already on DVT prophylaxis for other reasons. Many of the studies show breast cancer to be the most common cancer in relation to having a catheter in place. And then after breast, lung, colorectal, and upper GI were seen as the most common sites of primary cancer. Primarily adenocarcinoma, about 50% had mets, and 97% were on chemotherapy. In regards to the results of this study, so at 12 months, 3.8% of patients had CRT. So this is lower than the number that was seen for PICs, which is expected, as ports are thought to be less thrombogenic than PIC lines. And 9.6% were found to have VTE unrelated to the catheter itself. So, in all of these patients, despite having catheters, they still were more likely to have VTE than CRT, which I think is an interesting point. Of those who had of the 106 patients who had a upper extremity DVT, only 5 patients, or 0.2%, had PE. And this is pretty consistent with other data, which shows that clinically significant pulmonary embolism in association with CRT is quite rare. In terms of the risk factors that they identified for catheter-related thrombosis, they found cephalic vein use for the catheter insertion had a higher risk of being associated with CRT, whereas use of antiplatelet agents at baseline was found to be protective. The final study that I'll talk about for epidemiology is one by Ellis et al. Published in 2020. Again, a very large number of patients, so 3,000 patients, 5,000 catheters, median age was 56, primarily PIC lines, but there was a variety of lines looked at here. Again, primarily right-sided, primarily double lumen, and about 50% in this cohort or hematological malignancy. Very similar rates to the previous study. So 3.6% of lines in this study resulted in CRT. And as I quoted before, 95% of the CRT developed within 100 days and 75% within 26 days. So if you're really falling outside that range, it's much more unusual. And interestingly, in this study, 145 of the lines out of 177 were removed for thrombosis, which is not quite consistent with guidelines at this point. And this is just sort of showing their baseline characteristics and showing factors that were associated with higher risk of thrombosis. So we can see here, interestingly, those who are 50 to 61, for whatever reason, had statistically significantly reduced number of thromboses compared to those who were younger. And that continued on with the multivariate analysis. And the number of prior CRTs was also associated with a higher risk of having a recurrent CRT. PIC lines, as we know, do have the highest risk of having CRT, with a hazard ratio in this study found to be 22.2, which is very, very high. However, I will note again, there was the majority of the patients, 76% did have PIC lines. So hard to say if there was just insufficient numbers to really get a good idea of what the risk is in the other types of patients. And this is from a review, or a couple reviews. This one was published by Dr. Lee in 2012. And just looking at different factors to consider when looking at how likely it is that someone has a CRT. So PIC lines most likely to have a catheter-related thrombosis, with the port being the least likely. Material-wise, silicone or polyurethane found to be less thrombogenic. Valved catheters found to be less thrombogenic. Having the catheter tip more proximal to the SVC is found to result in more endothelial disruption and therefore felt to be more thrombogenic. having more lumens and therefore having more disruption to the vessel space and vessel flow, more thrombogenic, having catheter occlusion. In terms of vein entry site, so we say jugular or subclavian better than femoral. In terms of insertion technique, using ultrasound is found to be recommended in terms of reducing risk of clot. And then right side insertion has often found to be beneficial over left side insertion. And then in regards to patient history, so high risk or history of VTE, heritable thrombophilia, infection, and depending on the tumor type, these may be patient-related factors that make it more likely to have catheter-related thrombosis. This extra study here just also showed that particularly factor V Leiden and prothrombin mutation were found to have ORs of 4.6 and 4.9 respectively of CRT, and BMI as well as chest radiotherapy were also found to be other significant risk factors for CRT. In terms of complications, so why do we actually care about CRT and what does it actually mean for our patients if they have a catheter-related thrombosis? So possible complications include post-thrombotic syndrome. Interestingly, in upper extremity DVT, there is a higher incidence, PTS does seem to have a higher incidence than in the lower extremity. But in catheter-related thrombosis, it does seem to be a lower risk compared to those who do not have a catheter. We do not recommend routine screening for pulmonary embolism as often it has been quoted in literature that the PEs associated with catheter-related thrombosis are not commonly clinically significant, but the incidence is felt to be around 5 to 15%. SVC syndrome, as well as loss of catheter function, are also other complications to consider. This is a study that was published in 2018, and it was just looking at patients with upper extremity DVT, including patients who had symptomatic as well as incidentally found VTE. Again, very similar distribution in terms of types of tumors compared to the other studies. So primarily breast, colorectal, GI, similar distribution of female to male patients to other studies. Interestingly, this only 13 of the patients were found to have a high Karana score. This was a retrospective study of note. 60% were on chemotherapy, and the site of thrombosis was most common in the subclavian vein. Of this study, only 47 of them actually had a central venous catheter inserted. And the reason I wanted to just look at this a little bit was just to show that, interestingly, extensive upper extremity DVT did not seem to have more risk of complications compared to a single vein upper extremity DVT, which is sort of against what we typically tend to believe, more extensive, higher risk, but that doesn't seem to be the case here. And then interestingly, internal jugular isolated upper extremity DVT does trend to have, or does in terms of statistically significantly have higher risk of SVC syndrome, as well as decreased risk of post-thrombotic syndrome compared to other sites. And then finally, comparing CVC associated to no CVC, I found it very interesting that in this retrospective study, none of those with the CVC associated had a PE, which is again consistent with the fact that we think that there is less likely to be clinically significant PE in those with CVC or CRT. But similar rates of superior vena cava syndrome, less of the post-thrombotic syndrome, and that was statistically significant, and less of any complication in general. Of note, these patients primarily were anticoagulated with low molecular weight heparin, and bleeding occurred only in 5% of patients, with 3% of patients having recurrence after anticoagulation. This is just another systematic review from 2006 looking at post-thrombotic syndrome after upper extremity DVT. And basically it just shows sort of the ranges of PTS that were found in patients who had upper extremity DVT. This isn't just catheter related of note, but sort of between 10 to 46%, which is quite a significant range in regards to the possibility of having PTS. Another study published in Thrombosis Research in 2019, which is again looking at the rates of post-thrombotic syndrome. And again, just found it interesting. So primary is just those with unprovoked upper extremity DVT. Secondary included those who had cancer or catheter-related upper extremity DVT. And we see here that the rates of post-thrombotic syndrome did trend to be lower compared to primary. We'll now talk about treatment. So why do we treat patients with CRT? For a number of reasons. Number one, we want to reduce patient symptoms. And number two is really to prevent the symptom or prevent the complications. So PTS, catheter dysfunction, requiring removal of the catheter, and PE. There are a number of strategies that are often discussed, which we'll touch on today. Catheter removal and anticoagulation are the primary ones. For this purpose of time, I'm not going to go into catheter-directed thrombolysis or thrombectomy, but it is a consideration for patients, especially for those in my reading who have limited line access and for whom preservation of the line is extremely crucial, or who have very severe symptoms. There are limited studies looking only at CRT or upper extremity DVT in isolation. So practically speaking, most current guidelines say to base treatment on how treatment is done for lower extremity DVT or PE. In terms of the few studies that have been done looking predominantly at upper extremity DVT, and I will note that ATOM VTE was the only study that actually, the large RCT that was done in cancer patients that included upper extremity DVT patients. And all the other studies that look at upper extremity DVT are very, very small. So this one, for example, the catheter trial published in 2007 is commonly quoted as one of the early trials. There were 74 patients included only, so very, very small trial. Warfarin was used with dalteparin bridging, and patients were identified to have upper extremity DVT. And reassuringly, none of the patients who received anticoagulation required removal of the line, so there was no line failure. There was no VTE in those patients who were treated with anticoagulation, so no DVT, no new DVT extension or PE. And there were 3 episodes of hemorrhage, which is not uncommon in our population, of course. And again, I think this really emphasizes the fact that if you are using anticoagulation, there often is not a need to actually remove the catheter unless you want to stop anticoagulation or the line is no longer needed. This is a more recent study that was done in 2021. It was a multi-center retrospective cohort study looking at patients with catheter-related thrombosis and only hematologic malignancy. I found it interesting because they had a wide distribution in regards to management for patients found to have CRT. So there was 663 patients that were assessed, which was bigger than a lot of the other studies. Of these, only 19% received only anticoagulation, 58% had anticoagulation and catheter removal, 18% had catheter removal only, and 5% had no anticoagulation or catheter removal. Primarily treated with low molecular weight heparin, and for those who did have the catheter removal, interestingly, 68% were due to thrombosis, which, like I said before, like often I don't see people removing the lines for thrombosis. In terms of the results that we're seeing, so looking down here at the last box, 100 of the 663 patients had VTE recurrence at a median time of 60 days after starting therapy. Of those, 71 had catheter-related thrombosis, 53 were new, and 18 were progressive. And those who received only anticoagulation did not have any significant difference compared to those who had anticoagulation and catheter removal. Risk factors for recurrence were catheter removal only or no anticoagulation or catheter removal, which is sort of as we would expect. This is a study, the Catheter-2 trial, and this is interesting because a big question that comes up now is if it is safe to use DOACs to treat patients with catheter-related thrombosis, because we have neither very good studies looking at just upper extremity DVT or looking specifically at catheter-related thrombosis. So in this study, it was a very small study, 70 patients. It was a prospective multi-center study, and it was looking specifically at the population of symptomatic upper extremity DVT with metastatic disease and with CVC. So all these patients received anticoagulation, and again, all the lines were preserved, so 100% of the lines could continue to be used through the duration of treatment. There was only one case, unfortunately, that had recurrent VTE. It was a PE, and it did end up being fatal, and it did bring into question whether or not rivaroxaban truly should be used, as it was quite a significant event. And of course, consistent with other studies looking at the use of DOACs, there was a higher risk of bleeding, so 13% major or clinically relevant non-major bleeding, primarily looking at this box here, GI, GU, and urologic. Yeah, and then in terms of the patient population, so primarily PICS again, a few ported cats, and then primarily breast, colon, colorectal, which is very much like many of our other studies. This is another study from 2021, so just last year, that was looking at patients being treated with upper extremity DVT, not only for cancer, and it was a prospective cohort study looking at DOACs. And so this study was divided into patients who had cancer, did not have cancer, and then different types of risk factors, which I thought was a really helpful way of breaking down the sort of the patient population for this in this study. In the population we're looking at specifically, so we're looking specifically at the cancer patients and those who had a PICC line. And we can see here that more than 50% of the patients included in the study who had upper extremity DVT did have a PICC line in place, which is consistent with what we know about patients who have who develop upper extremity DVT in the cancer population. This trial is looking at sort of what the risk was of recurrent VT on treatment and post-treatment, both for active cancer and for non-cancer risk factors. So during treatment, very few recurrences, so only 1 out of 55, and then sort of a 5.5% risk of bleeding, 13.8% of major bleeding, 13.8% of major or clinically relevant non-major bleeding. Off DOAC treatment, interestingly, unfortunately, many of the patients were lost to follow-up as a result of patient death. But there's only 11 patients left, and of those, 2 had recurrent VTE. Hard to say what that means in the context of a very small patient population that was left, but does raise the question about duration of anticoagulation, specifically just for this one study. In terms of what this all translates to in terms of the guidelines, so I primarily looked at the CHEST guidelines as well as the ASH guidelines. So in the 2016 supplement for antithrombotic therapy for VTE disease, for prevention of thrombosis from the 9th edition. So what they recommend, starting at 9.3.1, is that in most patients with upper extremity DVT associated with central venous catheter, they stress the catheter not be removed if it's functional and if there's an ongoing need, because as we saw, line function can typically be preserved, and anticoagulation alone has been found to be pretty similar in terms of efficacy of preventing recurrence compared to those who had catheter removal as well as anticoagulation. In patients with upper extremity DVT that involves the axillary or more proximal veins, they suggest a minimum duration of anticoagulation of 3 months, which is consistent again with sort of, we do see that there is a risk of recurrence after stopping anticoagulation. For 9.3.3, in patients who have upper extremity DVT associated with a central venous catheter that is removed, they recommend that you do not need further than 3 months of therapy. And then in those who you do not remove the central venous catheter for 9.3.4, they recommend continuing anticoagulation as long as the central venous catheter is in place, over stopping at 3 months. The ASH guidelines, I could only find this one recommendation, 29, which really just recommended keeping the CVC over removing the CVC. In terms of the expert or Canadian expert consensus that's actually going to be reviewed by Dr. Lee in September, they say that looking at upper extremity DVT and catheter-related thrombosis, based on the available evidence and expert opinion, in terms of choosing the type of anticoagulation, because our study is looking directly at upper extremity DVT and catheter-related thrombosis, it's quite limited. So they say really follow a similar set of guidelines as you would for lower limb DVT and PE, based on the factors discussed, which we will talk about next. Thromboprophylaxis is something that's been explored quite a bit for patients with catheter-related thrombosis, just because of its high prevalence. I do wonder now, sort of with the lower rates that we're seeing of clinically significant upper extremity DVT in the context of catheter placement in cancer, if this will continue to be something that people are exploring. But I will talk about a study that is currently being assessed on thromboprophylaxis in the context of catheters in cancer. So right now, we do recommend to maintain patency of the lines that ports should be flushed monthly and all other lines should be flushed weekly. So PICCs, as well as filled catheters primarily. They have done studies looking at heparin flushes versus normal saline flushes and found them to be essentially equivalent, and therefore no strong recommendations regarding which type of flush to use over the other. There are a number of older trials that have assessed the use of pharmacologic prophylaxis. So VKA as a fixed dose, VKA at a lower target of an INR 1.5 to 2, low molecular weight heparin prophylaxis. But to date, no studies have assessed DOACs yet, but there is one currently in the works. The WARP study is probably the most commonly quoted study that I've seen when looking through all the numerous review articles I read on catheter-related thrombosis. It was done in 2009 by Young et al., and it was essentially comparing warfarin at a fixed dose, so 1 milligram daily, versus warfarin at adjusted dose with a lower target INR, so just 1.5 to 2, versus placebo. And I found this interesting because I've never seen anybody use a lower adjusted dose of warfarin before. But I mean, we'll talk about the results, but it seemed to be efficacious in this case. The outcome for this paper was radiologically proven symptomatic CRT. And the way that the patients were randomized was quite interesting. So first they were divided either into having benefit likely from warfarin or uncertain warfarin benefit. And the clinician would decide sort of which branch they would go into. If they were determined to benefit from warfarin, then the randomization was to fixed dose versus dose adjusted. And then if they were assigned to uncertain warfarin benefit, then they were assigned to either no warfarin or warfarin at a fixed dose or warfarin dose adjusted, depending on their willingness to participate in dose adjusted warfarin. They did not compare all the arms together. So in the comparison arms, if they went into these assigned to certain warfarin benefits, then basically they basically looked in the left side at no warfarin versus warfarin, but none of the 778 in this certain warfarin benefit were assessed during this. So they see that there's no warfarin or warfarin on the left, and on the right you get the fixed dose warfarin versus dose adjusted warfarin, and in that group, none of the people who were not willing to participate in dose adjusted warfarin were included in that randomization. If you have questions about that, if that's unclear, you can ask me after. So first, comparing no warfarin to warfarin, they did not find any difference in regards to catheter-related thrombotic events. And there was a trend towards more bleeding, which is as expected. However, interestingly, looking at the dose evaluation, they did find a statistically significantly reduced number of catheter-related thrombotic events in those who had dose-adjusted warfarin compared to fixed-dose warfarin. And this was, there was a trend as well towards reduced all thrombotic events with the dose-adjusted warfarin. There was a trend towards increased bleeding with the dose-adjusted warfarin, but it was not statistically significant. Another commonly quoted study that was done in 2013 by Lavau, Dens et al. Was comparing low molecular weight heparin to fixed dose VKA to no prophylaxis for 3 months for patients who received a central line, had solid cancer, and were on chemotherapy, primarily ECOG 0 to 1, but some 2 as well. And in this study, they found, so this included both patients who had symptomatic as well as asymptomatic thrombosis. In terms of what they actually found, so for those who had DVTs, they found that comparing no anticoagulation to be on some type of prophylaxis, there was a statistically significant difference. However, when comparing warfarin to low molecular weight heparin, there was no statistically significant difference between those two arms. Looking at the symptomatic thrombosis, we can see that there was 9 patients who had a CRT in the control arm, 0 in the warfarin arm, and 3 in the low molecular weight heparin arm. So significantly reduced number of symptomatic thromboses whenever receiving prophylactic anticoagulation in this study. This study is from 2006 and is looking primarily at dalteparin, just so that we can look at one. This is the most commonly looked at one with the strongest, what's the word? Which was found to have the highest, most reliability in many of the systematic reviews that were completed. And this was comparing dalteparin to placebo, so 5,000 units to placebo, and assigned a 2-to-1 ratio. Again, it was a multi-center RCT, double-blind and placebo-controlled. We can see here primarily solid tumors, age approximately the same as other populations, and primarily Caucasian here. Looking at the frequency of catheter-related thrombosis during the study, so we can see here that there was numerically an increased number, there was a similar number from a percentage perspective of catheter-related thrombosis or complications in the dalteparin and placebo arm. And interestingly, there was also no significant difference in regards to bleeding between the dalteparin and placebo arm. Looking both at asymptomatic CRT, catheter-related infection, as well as non-catheter-related venous TEE, there was no significant difference in any of these arms. Thankfully, there is a Cochrane review from 2018 that Kahala et al. Completed that looks specifically at this topic that combines multiple RCTs, so 13 RCTs with a total of 3,420 patients, looking specifically at the utility of consideration of thromboprophylaxis in the context of catheter-related thrombus. What they found was that comparing low molecular weight heparin to no low molecular weight heparin, there was a reduced number of symptomatic CRT at 3 months with an RR of 0.43 and 95% confidence interval of 0.22 to 0.81. There was no benefit for mortality, and there was no increased risk of bleeding with this. There was no significant changes in terms of VKA versus no VKA or low molecular weight heparin to VKA in the further analyses that were done. The conclusions from the author was that there was moderate certainty evidence that low molecular weight heparin reduces catheter-related VTE compared to no low molecular weight heparin. This is just the summary table from that study, and we can see here that there were 1,089 participants in 5 RCTs comparing low molecular weight heparin to no low molecular weight heparin, again with that risk ratio of 0.433. And that would mean essentially going from 67 per 1,000 to 38 fewer per 1,000 if you were to add on low molecular weight heparin. And as I mentioned before, no difference in regards to mortality, major bleeding, or minor bleeding. This is the forest plot that was created. And as you can see here, the Carthouse study and Levaudin study have the highest weight and are often quoted when looking at low molecular weight heparin as thromboprophylaxis in the context of CRT. Looking at VKA, we can see there is a trend towards reduced catheter-related thrombosis, but it was not found to be statistically significant. And there's also a trend towards more major bleeding, but again, due to only having 2 RCTs and low certainty of evidence, it was not found to be statistically significant. Comparing a low molecular weight heparin to VKA, interestingly, there was only 2 RCTs, but despite the fact that VKA was not found to actually reduce CRT, the relative risk of developing CRT was higher with low molecular weight heparin compared to VKA. So the risk ratio was 1.83. This is not statistically significant. Only 327 patients in these 2 RCTs, very low certainty of evidence. So basically, they're thought to be equivalent in this scenario. There are no studies yet that look at the use of low-dose DOACs for the purpose of preventing CRT, but there is a study that's coming out. It's called Trimline, and they're assessing the effect of rivaroxaban 10 milligrams daily versus an identical placebo in preventing CRT. Their major outcomes are major VTE prevention and estimates of major bleeding. And the completion date is estimated to be September 2026. So stay tuned for the results of that. In terms of what guidelines currently say about the use of thromboprophylaxis in the context of catheter-related thrombosis, CHEST has recommended against the use of routine prophylaxis with low molecular weight heparin and suggests against the use of prophylactic VKAs as well, despite the results of that Cochrane study. And they go into it a little bit more in the ASH studies regarding their reasoning. So same thing, they recommend against the use of parenteral thromboprophylaxis in the ASH guidelines, as well as oral thromboprophylaxis. And the reason is they say there's a low certainty of evidence of a net health benefit from low molecular weight heparin over no thromboprophylaxis, included that the balance of the effect probably favors low molecular weight heparin. However, given that it is so resource intensive and has associated costs, and that the cost effectiveness is variable, they agreed that for most patients, you did not need to be on low molecular weight heparin, but for some patients, it would be reasonable. So like many things, if you feel like your patient has had a previous, catheter-related thrombosis before, they are getting a very thrombogenic type of chemotherapy, their Corona score is high, and there's someone that you worry about who has very limited access, consideration for a low molecular weight heparin thromboprophylaxis would be reasonable in this scenario. And that is all I have for today's presentation. Are there any questions?
Hello, I don't know if this is working.
Yeah.
Yeah. Hi, Alina, it's Taylor, down the hall. That was awesome. Thank you so much. I had two questions, both kind of clinical situations that I have run into and have been unsure of. And so, partly questions to the whole group as well. The first situation is someone who has, this type of situation you've outlined, cancer, they have a central line in and they develop a new DVT, but the line is no longer needed. And the question always comes up is like, how soon after the DVT diagnosis and the start of anticoagulation can one safely remove a catheter, with the common concern that, you're going to mobilize this fresh clot and it's going to break off and cause problems. And then the other one is, I'd be curious to know what if you came across in the literature or what everyone's practice pattern is, if people who have cancer, they have a catheter, they develop a catheter-associated thrombosis, they're treated for 3 months, the line is out, but their cancer is still active. Mm-hmm. Would you, continue with therapeutic anticoagulation or prophylaxis or stop, or just kind of what people's thoughts are on that? I know that was a lot, but thank you.
So I will open it up to the floor as well, but in regards to what I've read, so for those who are going to get the line removed, I've typically seen sort of quoting between 48 hours and 7 days of anticoagulation before removal. It's sort of varied depending on sort of which review I've read. And in regards to your second question, so I think they do directly talk about this in the guidelines. And I think what they're essentially saying is, because we think that the catheter is the etiology. I think here, yeah. Because we think the catheter is the etiology for the blood clot, and they're often not clinically significant, unless you have like another DVT somewhere else not related to the catheter, there'd be no reason to continue anticoagulation past the 3 months, because the catheter is what really introduced the thrombogenic risk. So I think that a catheter-related thrombosis in cancer is not the same as other clots in cancer from what I've read and what I understand based on the evidence. But I'd love to hear other people's opinions on that as well.
Thank you.
I wonder if it's like, the way I think about it is that maybe you can finish the 3 months and then apply Corona score. And then if the patient is high Corona, then continue on some kind of low dose prophylaxis. But if they're low Corona and they're walking around as an outpatient, maybe they don't need it. That's my 2 cents on that situation.
Hi everyone, it's Aggie. So I feel I need to sort of chime in. And so all of you know, there's really no evidence to sort of look at this. I mean, there are a lot of sort of factors in these patients. What I do find, practically speaking, is for most of these patients, once you've finished 3 months of anticoagulation, if the patient's catheter still needs to be in, it's easy to just continue anticoagulation. It makes sense because the provoking risk factor is still there. And if they're receiving chemotherapy, their cancer is still active, sort of thing. So we basically continue as long as that happens. But in the scenario that, sort of Taylor mentioned that, okay, the patient has the catheter is out, there is no, obviously, and you've completed 3 months of treatment, but there is still cancer. I have to say that's actually not a common scenario. What I find is that, the patient still has cancer. They don't remove the line. If they have a port, they leave them in because they think, well, there's a high risk of relapse for the cancer. So there is something, the cancer is still ongoing. So something is usually happening with these patients. They're either getting more chemotherapy, or they have metastatic disease, and they leave their indwelling lines, especially if it's a port in place sort of thing. Now, if it's a PIC, they will tend to remove it because, PICs don't last that long and they're the hassle and stuff, and certainly associated with more complications, especially infection. So that scenario often, like, it kind of sorts itself out. Do you know what I mean? I have to say it's very uncommon. I encounter where there's a cancer patient, the cancer is still active, the line is removed, and I don't know what to do. I have to say, maybe I'm just not paying attention, but they've rarely sort of come up as kind of a therapeutic dilemma, or what do I do sort of thing. I don't know if others have had more experience or can recall what happened. In terms of the other question, when it is safe to remove. So when I was training, the sort of first line therapy used to be remove the line. You just remove the line, and most of the time the patients then get anticoagulated. And we started challenging that sort of approach, because we said, well, you remove the line, but the patient still needs the line. So we're now putting another line on the other side, but there's a clot there. Why wouldn't we just anticoagulate them and leave the line in? So because of that sort of discussion, over time, practice did change over to just leave the line in, anticoagulate them. And if you need the line, just don't pull it. If you don't need the line, of course, pull it, because you don't need to leave this nidus, of infection and recurrent thrombosis in. So in the old days, nobody thought twice about when is it safe to pull it. Let's just pull it. And so that happened most of the time, and was rarely reported in literature that somebody would have a fatal PE because of it. It's very, very rare. So I think most of the time, again, if they have a clot, the line is not needed anymore, you could certainly pull the line. Now, at the same time, you say, well, can we anticoagulate for a week before we pull it? Sure, that's fine too, right? And again, that whether that reduces the risk of PE or not, nobody's ever really looked into it. I recently had a patient with like massive SBC syndrome, brachiocephalic clot, IJ clot. It was related to her perm cath. I mean, she actually didn't have cancer-associated thrombosis, but the IR guys were all very scared about pulling her perm cath. So they insisted, because they're the ones who have to pull it, they insisted that, we anticoagulate her for a month before we kind of re-image her and see if the clot is gone. And thankfully, a month later, her clot is gone. So we're now going to remove it. So, I'm not sure it makes a huge difference, to be honest. And I think it really just comes down to, again, sometimes logistics and stuff. Anybody else? Paul, Leslie, Ala?
I agree with everybody's uncertainty.
Yeah. I mean, this is, oddly, this is an area that really has not moved forward in terms of science. A lot of the studies you've quoted, almost a decade long. I mean, CHEST guidelines 2016, that means the evidence are at least, going to 20, 14 or something, right? Because it takes time for them to review all the evidence and stuff. And so there's just not been a lot of investigation looking at really prophylaxis or even treatment. And I think overall the incidence of catheter-related thrombosis has gone down sufficiently that, you know, people just have decided, look, if there's a clot, we'll deal with it and we'll treat it then, as opposed to be all gung-ho about, primary thromboprophylaxis. So this is why Trimline is taking forever to recruit. And, you know, I think Rick Ikasaka, actually Rick was a fellow here for a little while. You know, he's the PI for the study. So so poor Rick, he's just, yes, he'll retire before the trial is going to be.
Oh, no.
Yeah,
But
Rick and I were in Ottawa together, and he started the pilot when he was PGY 7 there, and recently he told me the pilot's just done. So that's how many years now? That's at least 5 years for the pilot. So I don't know how long the real one will take.
yeah, so I mean, like I said, the incidence is just low enough that people are willing to we'll just deal with it when it happens. I think the question sometimes does come up in somebody who's already had a clot, for example, right? You know, do you do secondary thromboprophylaxis in those patients? And, you know, I deal with those on a case by case basis. You know, some of the patients are very keen. They do not want to have another clot, and, you know, they'll do whatever. And other patients, you know, can't even remember what their last clot was about, you know, doesn't have PTS, doesn't really think twice about it. And they say, oh, you know, I had a clot, it was treated, didn't really bother me. So, you know, so that's their experience coming into it. And so they don't want primary thromboprophylaxis. So it's quite variable. And again, because there's no evidence to say you need to or you don't need to. I mean, clearly these patients are more likely to have a clot. But again, it's never going to be higher than sort of like a 10%, which seems to be kind of a rough cutoff that a lot of people, you know, expect. Like when we talk to oncologists, sort of what is the cutoff of, of the incidence of DVT and PE before you would prophylax somebody? And they kind of uniformly say 10%. I don't know why, but, you know, maybe they think this is uncommon enough. Nobody's ever going to reach that bar, so they never have to deal with it. But they often will say, you know, 10%. Anything less than that is just not worth their while to sort of to pay attention to.
Sometimes what I find uncomfortable to deal with is the intensity of treatment if the patient's platelet is going to fluctuate, which happens a lot in hematological malignancy patients. And for better or for worse, I've just been treating, you know, line-associated clots as low risk, so no need to transfuse, just titrate the delta parent based on their platelet count. I don't know if that's what everybody else does, but for anything else, well, for PE, then I definitely recommend transfusion for the first month to see at least one bag to see if they can receive higher amounts, but not for non-catheter sort of DVT. But that's just what I've been doing. Don't know what other people do. I'd love to hear what other people do.
Ben, I have that same question. This year's ISTH, someone presented, I think it was a illustration or a poster that talks about exactly that. They were not transfusing for low risk clots, which they define as catheter associated subsegmental PE or distal DVTs. But for the PEs and proximal DVTs, they were transfusing for a month, treat the first month, and then go from there. So that was just one thing I saw at the Sears ISTH.
So that is actually consistent with the ISTH subcommittee on hemostasis and malignancy recommendations that was published in 2016. So that recommendation for kind of not be aggressive and do not transfuse platelets for catheter-related clots has been around for a while. So again, mainly because folks have felt that, you know, these are sort of lower risk clots for clinically significant recurrent thrombosis or PE, that we don't have to be as aggressive. So that's yeah, that's how I would manage them. And I think the group that really wasn't talked about, I think Elena didn't sort of cover, and that's largely because there's not a literature on it, are actually all the hematological patients, right? All acute leukes and stuff who actually are the ones with big central lines for a long period of time, severe thrombocytopenia for protracted periods. And, when they get clots, it's head scratching every time kind of thing. But there was a recent US study. It was a prospective study, and I can't remember the name, but Su-Fei Huang is the PI. And so they just did a prospective study of just tracking how everybody were being managed. So it was an observational study. It was not an intervention study. It was just people did whatever they wanted to do, but it was just all followed prospectively. And they showed that basically, and it included a lot of hematological malignancies and line-related clots. And that basically, again, sort of the half dose low molecular weight heparin with a platelet count 20 to 50 and nothing below 20, that seems to work. And that seems to be associated with a low risk of bleeding. So that's probably an okay approach. I think the group in the US is proposing doing a randomized trial. I'm not sure, again, there'll be a lot of appetite for that because it's complicated. And then another group, actually very distinctly different, and I know actually we're probably guilty of ignoring them a little bit here in our group, are the pediatrics, right? So the kiddies, vast majority of their clots are line related. Vast majority occur in patients with ALL because they're the ones who it's the primary hematological malignancy, and they're the ones getting L-asparaginase and lines as well. And line-associated clots are much more sort of aggressively treated in those kids because, literally are lifelines for these kiddies, and they get a lot more extensive like collateralization and loss of venous, access. Maybe because of the L-asparaginase, maybe because the catheter to blood vessel caliber, right? It's very different, right? Like a little kitty with a catheter in the, her vein, a large circumference of the vein it's actually occupied by the catheter. So there's probably more significant venous stasis in kids with lines in than for adults. And that's also why, we see more clots with like double lumen picks than single lumen picks. Again, just because of that additional venous stasis from the occupancy of the blood vessel by the catheter itself. So again, that's a really interesting group, and, maybe we could get them just helping to sort of talk to us one day about sort of approaches in pediatrics and how that's very different, and their dose requirement for low molecular weight heparin also very, very different as well.
Okay, it's 5:30. We're rarely on time, but the weather is nice. If there's no more questions, I think we should all go enjoy the sun. Actually, Ben just have his hand up.
I think he's meaning to clap.
Yeah, that's a clap emoji, Tony.
Well, thank you very much. That was great discussion. Enjoy the last sort of week of summer, guys. I'm gonna rejoice because my kids are going back to school.
Okay.
Thank you.
Bye-bye.
Thanks, everybody.
you.